Hi, thanks for clicking on. This is Great Clips 2023, a collection of the best of point of care ultrasound images that we've had for USACS in Mecklenburg over the past year. You guys had some great studies that you put forth and saved for me. So I really enjoyed seeing a bunch of the images. I think I started with 45 different studies that I thought were really great, but I've got it whittled down to these 13 or 14 that are going to be up for voting. So you can vote for you all, and there'll be prizes at the end of this. I thought that would be kind of fun. So we'll get some prizes out to the top three. So at the end of this, if you want to, click on that SurveyMonkey link in the email and then submit your top three, and the top three vote getters ultimately will get some prizes. Nothing terribly fancy. I'm not giving out thousands of dollars or anything, but I thought it would be kind of a fun way to wrap things up for the year. Nonetheless, I first and foremost want to say I'm sorry to anybody if I mess up your name. I unfortunately do not know everybody that's included here, but I wanted to make sure that I said that up front. But if you want to correct me on your pronunciation of your name, please do. Please send me an email or something. And again, I apologize. You're not going to be voting on any of my images. I did include some of my stuff. I thought that some of my stuff was good to share. I think sometimes it'll accent some of the other studies that I'm going to show. And then otherwise, there's a couple other things I thought were just kind of fun to watch and see. So there's a lot of good stuff here, things that I think that are really important and germane to our specialty of emergency medicine. And then also things that I think are just kind of fun and interesting. And it's always good to kind of share this, I think, because you guys should really kind of see the fruits of your labor, I believe. So we'll go ahead and get started. This first case is a simple thing. This is nothing of a magical diagnosis or anything here, but this is an ultrasound guided IV, and I just thought this was very well captured. I thought this was really beautiful images. These are pretty textbook. I would use this in a presentation to show people how to do ultrasound guided IV. So this one on the left is a needle in the vessel and long axis. This is by Dr. Berrigan down at Pineville. And then on the right, you have the short axis view, which I think is the catheter in vessel there. I don't know if that's the needle per se, but anyhow, I just thought this was really well captured. It certainly involved another set of hands to click record here, and I thought the extra effort was cool. You don't have to do all this for documentation of your ultrasound guided IV. Really what we need to see is just a catheter and vessel and maybe just squeezing down on the vein to make sure that it's got collapsibility there. But the extra effort I definitely appreciated, so I wanted to include this one here. The next one is a case of cardiac tamponade by Dr. Kavanaugh, also down at Pineville. So with this case, you can see the heart there. That's kind of obvious, of course. So, and around it in the pericardial space, you have this big, large effusion. What you want to focus on here is first and foremost the right atrium. So this right atrium, if you watch it, and when I get my cursor out of the way, the video will play a little bit better. So that right atrium is collapsing in systole. That's highly indicative of tamponade. And you can see the heart kind of quivering and shaking around. That's what you're seeing on your EKG when you see electrical alternans. So that's kind of an interesting part to see as well. There's other images that you should get with tamponade. This is just the one I'm including for the sake of brevity. But this is a really great image. You can also include this with IVC, and there's some MO cursor things you need to do with tamponade, but this is a really great case. It also kind of helps just this image itself, this clip itself, in conjunction with your physical exam, vital signs, that sort of thing can kind of really help clue you in that something needs to be done and that we have an effusion with tamponade physiology. So a great case there by Dr. Kavanaugh. This next one is one of mine. I thought this was kind of interesting. I've got a few studies in here with water bath. So I like to use the water bath for hands and feet. Basically, what that does is the water just provides a good acoustic window for structures. So if you just put the hand or the foot in like a Great Basin water bath, and then you just hover the probe over the area of interest, and you'll see really clearly what you need to see. And it's good for the patients because you're not putting the probe directly on the skin surface and causing them that discomfort from that. So this gentleman, this is what happens when you let a finger infection go for months, apparently. So he said that and I apologize for the background noise there, but he said that he has had this infection for like 3 months. He's had this swelling in his thumb, and it was driving him crazy. He eventually came in. So I guess if you leave a felon in place for 3 months, you can start to get this. So you see this jagged edge stuff in here where it looks like all this chipping and breaking up. If it cycles back through, there it is. That is all broken up pieces of bone, and that's osteomyelitis. The felon is over in here. You can see it kind of nicely there. That's a little fluid collection, and it's kind of just taken over the tip of the thumb. So this gentleman unfortunately lost his thumb. certainly definitely want to get into the hospital sooner than 3 months if you've got all this going on. So you don't always see osteomyelitis on ultrasound. That's not a common thing, but after a few months, you can see most things, I think. So that was just, I thought, kind of a cool case to see. Um, this next one is fantastic. The next two slides are of lymph node identification. So this first one is by Dr. Shirley over at Lincoln back in August. This really highlights the importance of soft tissue ultrasound and why we do soft tissue ultrasound before we do an IND. So on the left, you see this image of what looks like any other complex fluid collection, right? That just looks like a pure abscess. But this is why you put a color box over it. So you put a color box over it, and Dr. Shirley here has the color box on it, and you can see this campfire appearance. This campfire appearance is indicative of a lymph node. So this thing that looks like an abscess is actually a lymph node. So you definitely do not want to incise and drain this thing. So this is saving yourself and the patient some pretty big detriment from potentially opening this up and getting into a lymph node, which can cause some harm. So a great job of using ultrasound, using that color box to identify this as a lymph node as opposed to an abscess. And I think this sort of thing just really kind of highlights the importance of using your ultrasound for procedures where you can. If you do put the color box over something and it's an actual abscess, you will see a little bit of color here and there. You'll see like little dots like here and there, like a little red and blue occasional spots, but you won't see anything like this with a campfire appearance. This is clearly a lymph node. The next one, also, again, a lymph node here. This is by Dr. Deese down in Steel Creek in October. I really like this one. It shows not only the lymph node, you can see kind of that campfire appearance there in the bottom, but it also shows the abscess, which is superficial. So you see the abscess right there, just kind of beneath the skin surface. This is not a case where you can't IND the abscess, but it's just good to always use your depth to look around and make sure that you're not getting into a lymph node anywhere in the near area. So you can certainly IND this thing. You just want to be careful when you're in there with your forceps or your needle holders or whatever you're using to kind of break up the loculations. You just don't want to be very aggressive because you don't want to cause any damage to that structure that's a little deeper. So it's always good to kind of look around and make sure you've got everything in your window to see what you need to see. So this is just a great image of abscess with a deep lymph node there. So two great lymph node IDs there. I think it's really important, especially when you're in some of these hotbed areas. So like if you're in the axilla, if you're in the neck, if you're in the groin, where you know there's going to be lymph nodes in the area, look around the neighborhood there and make sure you're not seeing anything like this and try to avoid it if you can. So this is a great use of soft tissue ultrasound technique here. So the next one is a great one. Also, Dr. Bryant at university picked up this case of flexor tendinosynovitis. What you're seeing here is again, this is a water bath. So you've got the finger here. I don't know which finger it is, but this is the flexor tendon sheath. And then on this side, you can see the flexor tendon sheath here as well. There's a lot of fluid and edema in here. There's some complexity to the fluid right here. And this is indicative of something that would be highly concerning for flexor tendinosynovitis, especially in conjunction with your canaval signs. If you have a high index of suspicion, and then you can augment that exam with ultrasound to show this type of thing is there. When you call the orthopedic surgeon or the hand surgeon, you'll be much better off and much better supported in saying, I really am concerned here. I think this needs to be taken seriously and drained. So this person had FTS when they went to the OR, in part thanks to the good ultrasound imaging here by the good Dr. Bryant. The next one I'm going to show you is one of mine. I also had one of these cases, is also in a water bath. I've got the gain turned up a fair amount to kind of highlight things, but what you see here, and what I'm trying to show here is not just the flexor tendinosynovitis, but something that comes with it. So if you choose to start looking at trying to pick up FTS in a water bath or what have you, when you have these types of cases, you need to be aware of something called anisotropy. And this case kind of highlights that. So this one is a flexor tendinosynovitis. You can see here the tendon sheath as it comes across. And then you see the edema here in the soft tissue, and then there's complexity in here that's kind of invading into the flexor tendon sheath. Same thing over here. This is probably a better image. So you see the complex fluid collection, and it's getting into the actual flexor tendon sheath itself. So you can see that kind of outlined in here. So this is a definitive flexor tendinosynovitis just based on ultrasound. You don't always get to do that. It doesn't always get to that extreme, but that is the case here. And the other part of this is this thing called anisotropy, like I mentioned. So when you're looking at a finger, any finger, your finger, anybody else's finger, normal, healthy, unhealthy, whatever, you're always going to have anisotropy. So what happens is you have the linear probe that kind of goes across the surface of the finger, and you're never going to have that probe lined up perfectly angled across the flexor tendon sheath. The reason is the flexor tendon sheath, as it comes across and connects to joints, it takes little minor dips and turns, and when that happens, you get off-axis view of the tendon sheath, and you'll get this little hypoechoic region that occurs. So this is just anisotropy in here. It's a little bit of anisotropy in here, I think, too. It could be some complex fluid collection or breakdown of the tissue here. But I just want to say, that you will see these little darker areas, and that's normal, completely normal. What you're looking for is this complexity that kind of gets into the sheath and anything that's kind of surrounding it. So that's flexor tendinosynovitis, and then also some anisotropy there. But that person went to the operating room and had confirmed FTS as well. The next case is a vitreous detachment. Y'all do a great job of scanning eyes. We see a lot of eyes, which is awesome. I think ultrasound has been very well proven to be very sensitive and specific for retinal detachment, vitreous hemorrhage, I should say, and the like. So it's a great modality to use. We're not all great with our ophthalmoscopes, and this can be very helpful, especially for cases of detachment. So this one here is not a retina, it's actually the vitreous. So it's that little bit of layer with fibrous tissue that's kind of attached to the back wall of the eye. Sometimes with age that can kind of get separated, and that's not a full retinal detachment, and it's not quite as concerning as a retinal detachment, but it's a good diagnosis to make, and being able to kind of tease that out versus a retinal detachment is good. If you overcall this and call it a retinal detachment and they go see an ophthalmologist, it's no big deal. They'll just say it's a vitreous detachment, and it's not as big of an issue, and we don't really need to treat that right away. But it's a good thing to kind of tease out if you can. So this is good. This is by Dr. Tanzi at Steel Creek. What happens is you can see the lining of what's detached. This is the optic nerve. You always want to see the optic nerve, but what you want to see is over that optic nerve is the lining of what you're looking at detached. And if it is detached, does it go across the bottom all the way across, or does it tether down into the optic nerve itself? And this one does not tether to the optic nerve. If it's tethering to the optic nerve and it's floating around, that's a retinal detachment. This one doesn't tether there. So this is just a vitreous detachment, a good diagnosis to make, and accurate there. And I appreciated seeing that. So great job by Dr. Tanzi down at Steel Creek. In contrast, this is what the retinal detachment looks like. This is a good one. We had a bunch of good retinal detachments in the past year. This is Dr. Hassan, also down at Steel Creek. So you can see that serpentine movement of the retina as this person moves their eye around. It just kind of floats around snake-like there in the breeze. But you've got that, but you can see where it clearly tethers down into the optic nerve here. So this is definitely a retinal detachment, and this person was off to the ophthalmologist in consultation. So a good one there. Switching gears a little bit back to another heart case. So this is right heart strain with clot in transit. This is a case I had at Pineville in February. I don't work at Pineville much, but when I do, there's always some serious pathology. So you guys always get some great stuff there. But what you're looking at here is specifically in this right ventricle. You see this little golf ball, ping pong ball looking thing that's kind of bouncing around in there in the right ventricle. That's a clot in transit. That's a big problem. There's a differential for that. It could be like a piece of endocarditis tissue kind of floating around, but you have to look at the context here when you see that. And it's in this patient who is an obese female who has a history of PE and is supposed to be on Xarelto, doesn't take it, and is found face down, hypotensive, tachycardic, and hypoxic on a hotel lobby floor. It kind of makes sense that that's a clot in transit. Apologize for my dog in the background there, but you've got that clot just kind of bouncing around there. I've only seen that a couple times in practice, so I thought that was good to include. But you've got also here the right heart strain component of this. You can see this right heart, the right ventricle is much bigger than the left ventricle, and that's indicative of right heart strain. I had this weird run of cases. I had in a 6 weeks time frame, I had 3 cases of people where I had to give them TPA without a CTA. So I wasn't able to get them to CT because they were too unstable to get to the scanner. This person, I would have never been able to lay her flat. She was a complete mess. But we're fortunately able to get this and make a diagnosis and get her TPA, and she survived a discharge. Of the 3 that I had like that, 2 of them survived the discharge. The other one died in the ER, unfortunately. But this is a good case where you see that clot in transit. Right heart strain is a great modality for us in the emergency room whenever you've got a PE case or high suspicion. So Dr. Hassan has a good case here for subtle free fluid. I love this one. So this You guys do a great job of trying to capture ectopic pregnancy too, which I think is cool. I love using fast exam for things other than trauma, and this is one of those cases. So just to show you kind of briefly here, this is the free fluid I'm looking at. This is very subtle. It's very limited. When this person went to the operating room, they did truly have an ectopic pregnancy, and they sucked out, I think, between 100 and 300 cc's of blood. So this is kind of the early finding of that, this little slither of free fluid here. So I'll get this video going here on the left to kind of show it. So you see the bladder nicely. It's a nice full bladder for the acoustic window. And then off on the left, you'll see something kind of come into vision here, right here. That could be the ectopic. It could also just be the corpus luteum cyst. The ectopic can be a little bit sneaky and hard to find sometimes. So you may not always see the ectopic sac itself. It may be ruptured. It may be kind of distorted. It may be hiding behind the uterus or the fallopian tube or something. But you do ultimately, if I can get the video playing again, you do ultimately see, that cystic lesion, which may be it. And then you got there towards the end of the video, if we get there, is that little slither of free fluid right about in there, right there. Okay, so this is a good case where a good pickup of subtle free fluid by Dr. Hassan down at Steel Creek. And this becomes very important, of course, at Steel Creek. I mean, you've got to transfer this person. So the quicker you can get to this diagnosis, if you can get the ultrasound machine in the room and come up with the free fluid and a high index of suspicion for seeing this, you can get on the horn and talk to the OB and get the transfer in progress before getting your transvaginal ultrasound or any lab results back, which aren't probably going to be very helpful in this case. But you've got all this kind of in motion ahead of time, and you can really make a more timely patient management course just by using ultrasound early like this. So a great job here. Another one from Steel Creek, this is Dr. Boers. I'm calling this not so subtle free fluid. I'd include this, it's a rather obvious case of free fluid there out by the liver tip in Morrison's pouch here in the right upper quadrant view. And then down here in the pelvis, you've got some floating bowel loops and hemoperitoneum, which are cool to see. But I don't include this because it was, a diagnosis that was tricky to make. I mean, I think most people can do this sort of fast exam, and that's why we do fast exam, because it is that straightforward. But the good part about this, the astute thing on Dr. Boers' end for this case, I thought, was when I look back through this case and where this came from, this person had a trauma like 2 days before, and this person was taken to a trauma center 2 days before and admitted to the trauma center after a CT scan, and that CT scan showed a small amount of free fluid that the radiologist called ascites. I guess if the Hounsfield units on the CT scan are suggestive of ascites, you may be inclined to call it ascites, but this is a trauma case and a guy who had no other reason to have any free fluid in his belly, and it built up over time. They admitted him, they watched him, and they discharged him. And I'm not faulting the outside hospital. It wasn't an atrium facility, but I'm not faulting them at all. This isn't meant to or intended to dog that outside facility, but it's just a great case to highlight. I actually had a case last night at Huntersville where I had a case where a pregnant girl had a car crash and a seatbelt sign, and the initial, she didn't want the CT scan, which was fair, I thought, but the initial fast exam I did was negative, and then I did another one 2 hours later and there was free fluid. So, and that kind of excelled things, so she ended up with a CT, and we'll have to see how she does. But anyways, so Dr. Boer is very astutely getting that ultrasound on there to look and make sure there wasn't any change, and there was. So this person went to the OR at CMC, and they had a lacerated mesentery. So be vigilant if things aren't adding up, they aren't quite right, things aren't, getting much better with people, or God forbid getting worse. Just repeat your fast exam. And it's like this case I just happened to have last night too. Just repeat your fast exam, and you may pick up some free fluid that's developing. So this is another case of mine. This is an aortic dissection case. You can't really see the dissection flap too well in here. So this is a peristernal long axis view of the heart. There's a little bit of flap in here, I think right in there, that you can maybe tease out. I wouldn't call it based on that, but if you're really being picky, you can maybe pick it up there. But what I want to highlight here is a few things. One is the pericardial effusion itself. This is just a little piece of pericardial effusion here, and then you get a little bit here posteriorly as it kind of progresses through the video. Right in here, you see a little bit of free fluid, or not free fluid, but pericardial fluid. What you want to do is, and I'll show you a case of pleural effusion as well to show in comparison, but this is the descending aorta as it comes behind the heart, and you want to be able to judge where the fluid is based on that. So it's always important that you see this descending aorta. So if the fluid is behind it, behind the aorta, it's a pleural effusion. If it's anterior to it, then it's a pericardial effusion. This is just trace right here. It's a little bit more determinable here in the anterior aspect of the heart. But you can see it's kind of having a little bit of push down effect on the RVOT. So this is RVOT here. This is LVOT. So right ventricular outflow tract, left ventricular outflow tract, and then left atrium here. So it's kind of pushing down here. So you get a little bit of tamponade physiology from that. That can happen with smaller amounts of free fluid. For people with hearts that aren't used to pericardial fluid in the pericardial sac pushing down on it, their Starling curve doesn't really tolerate that well, as opposed to somebody with like a uremic pericardial effusion, or somebody with like lupus or something. Those tend to build up over time. There's some great cases of TB, pericardial effusions, with just enormous amounts of fluid in it, and people really tolerate it well because it's so gradual. But this shock to the heart with this abrupt amount of free fluid, even a small amount, can cause some physiologic change here. This wasn't so detrimental. This person wasn't hypotensive or anything, but you can kind of see how the effect is here. The other thing I want to show is these three sections. So the RVOT, the LVOT, and the left atrium, they should all be about the same size. This one is not the case. So this one's kind of pinching down over here, but it's roughly the same size when it expands back out and fills up. It's roughly the same size as the left atrium, but clearly the left ventricular outflow tract is pretty wide. When I paused this and measured it, there's something called the sinus of Valsalva in here. When I paused it and measured it, it measured 5.3 centimeters. If you're measuring anything greater than 4 centimeters, it's not good. That's an aneurysm, most likely. And you should be a little bit more vigilant there. But this one measured 5.3. So he had an aneurysm. It dissected and it tore down into the pericardium and caused this pericardial effusion. That's not a good sign. That's a really risky thing. That's a really life-threatening thing. Fortunately, this guy was young and otherwise healthy enough and did great and survived. These are the images here of his belly, just to kind of show you the dissection flap. So this is the aorta as it comes through the belly. So you have the heart and the diaphragm. You have liver over here, and you've got the aorta coming through here. This is the dissection flap in here. And as this kind of plays out some more, you can see in his SMA right here, you can see a little bit of a flap in there too. If you're really looking close, it's right in there. He had dissection that went through most of the vessels in his belly and down through his iliacs most of the way as well. It even went up into his neck. I mean, this was probably one of the worst dissections I've ever seen. And he survived and did very well. He actually was only in the hospital for about a week. If you're looking over here on this side, you can see over here, this is the aorta and transverse. So you have your vertebral body shadow here. This is IVC here, and this is aorta. You can see the flap in here of the dissection kind of flapping around as the video goes. I'll get it playing again. But you can see it kind of flapping around in there. That's an aortic dissection. So this is at university. We don't have vascular surgery there. So the sooner you make these diagnoses, like they're not going to take this guy to the operating room based on my ultrasound, of course, but you can at least say, hey, I've got a guy with a pericardial effusion and a obvious dissection here. It's going to need a cardiothoracic surgeon, most likely. You're going to have to, force this guy into the CT scanner, no matter how stable or unstable he is, because they can't operate this without those images. It's that important. So this is kind of one of those ones where you got to bite the bullet and take your recess stuff over there and get what you can get. But you can at least get the party started and get people on the phone to say, I've got this case, it's coming to you, we're getting the CT images, I just want to make sure it's on your radar so you know what's coming. And then, I promised you this image. This is a great one by Dr. Dorr. This is left ventricular dysfunction with the pleural effusion. So he does a good job of capturing that descending aorta here. And then behind it, you see all the free fluid. So it's not anterior to it, so that would be pericardial fluid. This is behind it, so this is pleural effusion. So we'll get the video going here. The other thing here is this anterior leaflet of the mitral valve is not coming anywhere near the septum. So this is a severe left ventricular dysfunction. This is a person with severe CHF and a pleural effusion. Good little case there by Dr. Dorr. You just got to make sure you get enough depth to see all that fluid. This is an LV dysfunction case I had. Anytime I have a STEMI, I try to use ultrasound if I'm not too tied up with the interchange and the phone calls and making sure everything's on board and getting them out the door quickly and all that sort of stuff. If I have a chance before the ambulance gets there, at least, to get the ultrasound probe on them, I like to do it because it kind of helps tell the story a little bit better, I feel. So what you see here, this is the LV, this is the parasternal short axis view, and you're kind of looking at the whole circle of the heart there. See if I can freeze it in a decent spot there. So what you want to look at is how the wall motion, how that wall moves with every systolic beat of the heart. So in here, this section in here, this So this is the septal, this is anterior, this is lateral, this is posterior, and this is the inferior section. And these are papillary muscles here. So this here, this anterolateral section here is not moving very well, and that's the wall motion abnormality at play. And it fits well. I'll show you the EKG in a second, but I kind of like how this always plays together nicely. When you see the wall motion abnormality plus the EKG, it kind of tells you where that culprit lesion is, and it helps them kind of know in advance what to look for in the cath lab. So when you see that anterior lateral aspect, you're thinking more LAD or circumflex. Over here in the apical four-chamber view, this guy didn't image terribly well, but you see some hypokinesis, maybe even akinesis of the apex, and then the lateral wall has a little bit of hypokinesis as well as the septum to a degree as well. I'll let that kind of play out for a second, but you can see how it doesn't squeeze as well in those areas there also. So this was his EKG. You can see the anterior STEMI, and then in the inferior leads, you have those reciprocal depressions. Had a lot of disease, tons of disease. He was referred to CABG. He had the 100% LAD lesion, which was probably the culprit lesion here. It could also be this 100% circumflex lesion too at play, but he also had a 100% RCA also. So fortunately, he had some decent collaterals keeping him alive. He was referred for CABG. He was turned down. He was too risky of a case for them to take. But they ended up going back and fixing his LAD and medically managing the rest. And I think he did okay and made it out of the hospital just fine, or at least as well as can be expected. Love this type of case here. This is a pneumothorax with a lung point. This is Dr. Russell's case up in Huntersville, July 21st. So what you're looking for here with thoracic ultrasound, this is great use of ultrasound for this. It's a really textbook image. So you've got the pleural lining here, and then you have A lines that repeat. So the pleural line will repeat with these A lines. So this is an A line here and an A line here. And basically they're the same distance from skin to pleura. It just kind of, the air in the lung will create this reverberation effect, and it kind of bounces back and forth. And what happens is it plays out in equidistant lines down deeper into your plane of view. So what you're looking at here is you see this little ants marching effect of the lung sliding nicely here, but up to here, this point here, it's not sliding on this side very well at all. It's not sliding really at all. So that's a lung point, and that's a pneumothorax. This is a spontaneous pneumothorax, and a person who ended up needing a chest tube. But a really nice pickup by Dr. Russell there. Good use of thoracic ultrasound. Thoracic ultrasound is not a terribly difficult thing to do if you want to just start going for it. We aren't credentialed for thoracic ultrasound, unfortunately. So if you do this and you do pick up any pathology, or anytime you're using this and charting on it, we're not really credentialed for it. So make sure that you're getting a secondary study with that, either a CT or a chest x-ray, which in this case they certainly did. But this is just a really nice pickup and a good image of a lung point that I wanted to share. So good job by Dr. Russell there. This is another good case by Dr. Boers down at Steel Creek. I love when people can kind of incorporate bowel ultrasound, also something we're not credentialed for, so you always need that extra study with you. But it's great when I see people doing stuff like this, because it kind of just, I don't know, it's pleasing to be able to make diagnoses with ultrasound and kind of see what's going on. And it kind of just keeps you, I don't know, it keeps me kind of fresh and wanting to go back to work when I get to see stuff like this. So you've got this ventral hernia. So you have the peritoneal wall here, and then the ventral hernia is very, very nicely imaged, and it comes through the wall there, and you see it poking through. There's a partial SBO associated with this. Clearly, this is going to need to be fixed surgically. But I froze the image here. Anytime you have one of the things you look for with small bowel obstruction ultrasound, there's several different things, but one of the things you're going to look for is dilated loops of bowel, just like you would see on an X-ray or a CT. So if it's more than 25 milliliters or 2.5 centimeters, whatever denomination you're working with there, that's indicative of an obstruction. So this person needed a surgery. A good job by Dr. Boers picking that up. It also confirmed on CT, so it was good to see. This next one I thought was really cool. This was at university. This is Dr. Cooley, who has unfortunately since left us, but always did a great job of getting these awesome ultrasound images. He was a great sonographer, but he is off to more gambling ventures and hiking and that sort of thing in Reno, Nevada now. But this was an awesome case he picked up in October at university. This is a penile urethral stone. So some stone that had formed in the bladder got itself out into the urethra and got itself stuck. This is the stone out here, and then this is like the glands of the penis right here. So it's out towards the end. It was almost there, and you see all this urethral dilatation from the obstruction. A urologist had to come in and help get this stone out of there. It's certainly not something I would want to be fishing out of somebody. I'd be fairly concerned I could be doing some damage there, but I've never seen that on ultrasound. I thought that was really interesting, but a great case by Dr. Cooley there. There's another case I had at university back in April. This is a retained wire. I promise you, I did not leave this wire in this poor lady. This has been there literally for 20 years. It was from a central line catheter that she had in her IJ and floated all the way down into her inferior vena cava. So you see the metallic foreign body. This is the heart over here, so it's reaching up into the heart. I think it actually did extend through the heart and up to the atrium and into the IJ vein as well still, but it's been there for decades. Nobody's taken this thing out. It's like adhered to the wall in places. So you see the metallic foreign body as it extends down the inferior vena cava, and then this is just a shot of it in a transverse axis. So you see the foreign body there, and the movie kind of plays out from like heart right there, and then it flows down into the inferior vena cava. You can see it there. And then I think this is the last one here. This is quadriceps tendon tear, also by Dr. Cooley. This is done on the dinosaur machine we have at South Park that needs to be replaced from like 5-6 years at least. We're working on that. Hopefully that happens soon. But anyways, the machine still works and still gets some decent images. I can assure you of that. This is the quadriceps tendon there, and you see it kind of broken up. That should be a nice hyperechoic line. I'll let it play back through again. There should be a nice like hyperechoic line here that's like straight through, and it's all broken up, you can see. So that's a tear of the quadriceps tendon. And you can see all this complex fluid. This is all blood in the superior knee over here. So tear here, fluid here. So it's always cool, I think, when we can make an orthopedic diagnosis that's not bony related, because we don't always get to do that. And you can do that with these bigger tendons, especially like the Achilles tendon. If you're really wanting to see or do something easy to kind of get yourself into looking at musculoskeletal tendon stuff, the Achilles is a great place to start, because you can very easily see Achilles disruption and fluid and the tendons all torn up in there. It's very easy to see and kind of cool to see. So anytime you get like an abnormal Thompson test, and you're really concerned about it, just take a look. You'll be impressed with the images you see. I think they're pretty cool to see. And it's always good to be able to make those non-bone related orthopedic injury diagnoses when we can. So that's it. That is the last one. Make sure you get your votes in. Just go ahead again and go onto that link in the SurveyMonkey link in the email and vote for your top 3, and we'll see who the winners are, and I'll let y'all know. This is just one last image I had of an IJ catheter I did. So whenever you see a valve, this is a vein valve here. So this is the valve of the IJ. You don't usually see those that often, but sometimes you do. And when you do see that, of course, you don't want to like put your needle through there and damage it. So if you do see it, you want to start a little bit more proximal. So that's what we did here. We just started a little bit more proximal, got the catheter in proximal to the vein, and then I went back and took a picture of the catheter kind of floating through the middle of that vein valve there. So again, get those votes in. We'll see who the winners are. Thanks so much to all of you for saving so many great studies this year. I had a fun time, reviewing all this and putting this together. So keep saving images, keep up the hard work, and keep using ultrasound to help out your patients. I really appreciate it. Hope everybody has a good holiday and a good new year. Thanks again.